Right. Dr. Ngwaru is a specialist obstetrician and gynecologist working here in Zimbabwe. He's a consultant at Paredenyatka Group of Hospitals. He obtained his Bachelor of Medicine and Bachelor of Surgery degrees in 2003, and he obtained his Master of Medicine in Obstetrics and Gynecology in 2015. Dr. Ngwaru is so much interested in gynecological endoscopy and is part of the current cohort of trainees. And he's also got so much interest in pelvic floor disorders and urogynecology. So Dr. Ngwaru is going to talk to us about sexual dysfunction and endometriosis. Dr. Ngwaru, over to you.
Thank you very much, Grant. Thank you very much. Can you confirm if you can hear me loud and clear?
Loud and clear, and we can see your screen also.
Thank you very much. I feel so humbled to present this presentation after some high-powered presentation. And I think it makes my presentation a little bit easier. It's not really high-powered as the previous three presentations, but I think it's an important topic. I'll try to explain why as we move on. I'm trying to move to the next slide. Okay, so female sexual dysfunction is often overlooked due to many reasons, including cultural beliefs. And in many societies, it's also considered as a social taboo. And not taking anything away from previous presentation, you can see that the main focus of this management was pain or self-fertility. And there is no talk of sexual function, because we viewed maybe the pleasure that female enjoys from sex is viewed as dangerous and desirable and often irrelevant. But sexuality and also enjoying sex is an important part of life. And I think in my presentation, I'll try to highlight that it's important for women and it's important for men to enjoy sex. And I think this comes from the poor understanding of sex from a male point of view, and also the understanding of sex from a female point of view. And it makes the studies in sex, especially so when there is a complex disease like endometriosis, where we are worried about more other important things like pain or fertility, it makes it not really relevant. But I would want to thank the organizers of this meeting that decided to include this topic in this session. So the WHO ICD-10 defines sexual dysfunction as various ways in which an individual is unable to participate in a sexual relationship he or she would wish. So if you're not able to participate in the relationship that you want to, then it becomes a dysfunctional. According to DSM-5, it's disturbances in sexual desire, in psychophysiological changes that characterize the sexual response cycle and cause marked distress and interpersonal difficulty. So this is a slight change from the DSM-4, which didn't really specify the duration of these symptoms. So in this DSM-5, they actually include 6 months and also the frequency that it should be present in 75 to 100% of the times. But in both of these definitions, it's important to note that they talk about a subjective distress criteria, that the person should acknowledge that there is some form of distress that is happening to that person. In this case, a female should report that there's a distress that is happening. She's not able to engage in sex activity, and this is causing a personal distress and interpersonal disturbance. I think this is more to do with psychology and psychiatry. So some of these things I'm not really a specialist in them, but we need to know that there is this what they call interpersonal distress. And then it also relies on the sexual response cycle. This has been much of a debate, the sexual response cycle, and I'll go into more details with it maybe in the next 2 slides or so. But it's also important to know that there is a psychological and a somatic component in sex in this distress, that there is a psychological component and there's also a somatic component. So the phases of this human sexual response has gone under evolution from the 1966, when some people tried to, Masters and Johnson, when tried to explain this. So they put it in a linear, they said it's a linear model of human sexual response. And they were talking about, you have excitement, then you have a plateau, you have an orgasm, and then you have resolution. And they were saying these stages follow each other. It was successive, so they call it a linear response. Then in the 1970s, Kaplan tried to introduce the concept of desire, that there is a sexual desire that should come before you get excited and you get a plateau and all this. So then he actually changed it into 3 phases, where you have the sexual desire, you have your excitement and orgasm. Basson looked more specifically on the female response, and people have accepted this, and they're also using it in the male sexual response. So in this model, they postulated that there is a motivational. So this motivational incentive cycle was postulated in the 1970s, late 60s, and then it came back in 2000 when they tried to modify it. So they say there's a motivational incentive-based cycle comprising subjective experience and physiological changes. And they also noted that, she also noted that women do not necessarily experience sexual desire spontaneously. There has to be a stimuli some way that comes. And then the desire is a response to sexual stimuli, creating arousal and desire to continue the said arousal. So it begins, in this model, it begins with someone who is in a state of sexual neutrality. Then you may seek or respond to a sexual stimuli, and that's activate the sexual arousal and desire. So this pattern, we have things that are coming from all forms of level, and such that it's a cycle rather than a linear description, as earlier on alluded to. This is just a diagrammatic representation of this female sexual response. And it's important for us to understand this so that we know where there is a disruption. When there is a disruption of this cycle, then we say there is actually a sexual dysfunction. So there are some women with some spontaneous sexual drive, then they have a sexual arousal, which then joins the arousal and the sexual desire. And the ultimate goal is to have an emotional and physical satisfaction. And this can be then lead to emotional intimacy, feeling of love, and so on. And this can actually be an input to a sexual stimuli and becomes a cycle. You can have biological stimuli, you know, also have some psychological stimuli that can also cause a sexual arousal, and the cycle goes on like that. I'm sure the next presenter will talk more about this psychology of sex and of endometriosis, and I'm sure they'll also touch on some sexual dysfunction. So accordingly, we have divided the sexual dysfunction into three levels, as opposed to the previous classification. So we have disorders of sexual interest or arousal disorder, where you have female hypoactive desire disorder. There's absent or diminished feeling of sexual interest, desire, or arousal. This can be subjective. Even when you try to stimulate the genital, there is actually no desire. Or it can be absent thoughts or fantasies and lack of responsive desire. So the woman doesn't even think of sex at all. There's actually no motivation, as we alluded in the motivational incentive model. There's actually no motivation for someone to engage in sex. And of course, all this reduction in sexual interest is beyond the normal lessening of desire in lifestyle as you have a relationship with someone. And then we have a persistent sexual arousal disorder, where you've got spontaneous, intrusive, unwanted genital arousal, tingling, throbbing, pulsating in the absence of sexual interest or desire. And this arousal is unrelieved by one or more is not relieved by one or more orgasms, and the feeling of arousal persists for hours or days. This is like the opposite of the hypoactive pattern. Then we have orgasm disorders. So despite a self-report of high sexual arousal or desire or excitement, there is either lack of orgasm, marked diminished intensity of orgasm sensation, or marked delay of orgasm from any kind of stimulation. Then we have disorders that we are more interested in, where you have pain in the genital. So they've been classified as genital pelvic pain penetration disorder. This includes dyspareunia, vaginism, and other sexual disorders, which I don't really need to go into details because we all are aware of these ones. So I try to look for information to look at the prevalence and associated factors of female sexual dysfunction in women. This is a paper that was done in Beijing. They looked at, it's a referral center in Beijing. They looked at women were recruited among inpatient scheduled for laparoscopic surgery based on signs and symptoms suggestive of endometriosis. And they used the simplified Chinese version of the female sexual function index to assess the sexual function. And they discovered that the prevalence of female sexual dysfunction was as high as 73% in those women with endometriosis. So it's that maybe women do not come and say, I have problems because of cultural barriers, but it is there in the population. And according to that paper, the major predictors of sexual dysfunction was the intensity of the pelvic pain and also the degree of infiltration of the endometriosis. In this paper, they looked at, they did a cross-sectional study. They looked at about 254 women with endometriosis, and they compared them with 329 patients without the disease. And sexual function score was assessed using the female sexual coefficient. And then they also looked at the Beck's inventory, where they used to assess anxiety and depression. And they noted that in women with endometriosis, they were affected in all phases of the sexual response, not only in pain, as we want to say, are you having pain, but they had no desire, they had a problem with sexual arousal, and also they had pain or penetration, orgasm, and satisfaction. And 43% of women with endometriosis versus 17% without endometriosis had sexual dysfunction. And the conclusion of that paper was that endometriosis have more than twice sexual dysfunction as compared to women without the disease. In this paper, this is a paper from India. We're looking at the situation in India. The important thing to note here is that, so they used a sexual function index of which a score of 26 was recognized as positive, and less than 26 was negative, it meant that you had sexual dysfunction. So in those women, we had 24 women had sexual dysfunction and 27 had no sexual dysfunction. And there was there's a statistically significant difference in terms of desire score, the arousal score, the lubrication, orgasm. And so in all parts of the sexual cycle, there was actually disturbance compared to those women who didn't have endometriosis. And this is from the same study. We show that as the degree of the endometriosis increases, so does the female sexual dysfunction. So in those women who had severe endometriosis, and all of them had sexual function disorder. So this slide just shows that the more the more the degree of endometriosis, the more you're likely to have sexual dysfunction. So this is just trying to explain, and that's the reference to that Indian study. I also looked at factors that influence sexual function in fertile women with endometriosis. They looked at 220 infertile women with laparoscopically confirmed endometriosis, and then they used the female sexual function index, the Pittsburgh Sleep Quality Index, the hospital depression scale, and the visual analog scale. And there was actually, they noted that the sleep quality, anxiety, and depression decreased sexual function, and the intensity of pelvic pain with an effect, had an effect on sleep quality and dyspareunia change in women with sexual dysfunction. And they concluded that the care of women with endometriosis, not only laparoscopic and medical treatment should be performed, but also the psychotherapeutic and psychosexual help should be offered in these women. So there is a high prevalence of female sexual dysfunction among women with endometriosis. It is not only pain. Women suffer all aspects of the female sexual response cycle, arousal, the desire, orgasm, and pain, and sleep quality, which can be related to the pain, anxiety, pelvic pain, depression, worsens female sexual dysfunction in endometriosis, and intensity of pain and deep infiltrating endometriosis are major predictors of female dysfunction. And female dysfunction increases with increase in the stage of the disease. So what about the treatment? This is a slide I took from one of the books that I used when I was studying for my MMed, and I still use, I still refer to the book, so it's a reference book. You see the factors that they list there as priority. There's no female function, there's no sexual function there. This is why I just brought it so that we can see that when we look at the treatment plan, we really think of the sexual function. And I think maybe after this we might change and also try to consider the sexual function. So this study, there was deep perineum and sex after laparoscopic excision of endometriosis. They looked at 68 women, and laparoscopic full excision of endometriosis was done. Following surgery, they were asked to use non-hormonal contraceptive devices. So they followed them at 6 and 12 months, and women with and those without uterosacral ligament endometriosis had significant improvement in deep dyspareunia. And subjects with uterine sacral ligament endometriosis reported increased variety in sex life, increased frequency of intercourse, more satisfying orgasms with sex, relaxing more easily during sex, and being more relaxed and fulfilled after sex. So it shows that the importance of doing surgery in these women, it also improves their sex function. I also looked at this, it's a systemic review when love hits, a systemic review of the effects of surgical and pharmacological treatment for endometriosis on the sexual function. They looked at about 1,000 studies, and only 22 studies suit their criteria. So they divided these studies into two categories, those which had for intervention and those with pharmacological intervention, and 17 versus 5. And both arms showed that there was a medium to long-term improvement, but not necessarily a definitive resolution to the female sexual dysfunction. So the ideal treatment for endometriosis-related female sexual dysfunction should be conducted by a multidisciplinary team that involves not only gynecologists, but also sexologists, psychologists, and physiotherapists. And improving global sexual function, not only just reducing pain at intercourse, should be considered as a major clinical goal for endometriosis treatment. So, in conclusion, or maybe what we might need to take home is sex is an important part of life, and women should enjoy having sex. And also sex function is a multidimensional phenomenon. And in endometriosis, it's just not the pain, but all aspects of the sexual response cycle that are affected. And female sexual disorder is more likely with greater intensity of pain and also in deep infiltrating endometriosis. And from a slight surgical and pharmacological intervention for endometriosis can lead to medium or long-term improvement, but not necessarily a definitive resolution of female sexual dysfunction due to endometriosis. So improving sexual function and not just reducing pain at intercourse should be considered as a major clinical goal for endometriosis treatment. Thank you. That's the end of my presentation.
Thank you, Dr. Stanley Ngwaru, for such a passionate and detailed presentation. Indeed, gynecologists must talk about sex because it is one of the problems that women face daily. So I'll leave room for one or two questions, one or two burning questions. All right, I don't see any raised questions or any raised hands or questions in the chat box. But remember, there is a discussion at the end of the day. So if you have any other questions relating to any of these talks, you can reserve them for the last segment of the meeting today. We will move over to the last presentation of this segment. The host, may you please allow Dr. Chinoperekwe